Hi everyone. So we're going to talk about hypercoagulation for this section. And hypercoagulation disorders there's quite a few of them. We're going to talk about the most important ones. Factor V Leiden, which is the most common, protein C deficiency and protein S deficiency, Prothrombin G2021-0A mutation, antithrombin 3 deficiency, and lupus anticoagulant disorder. And I don't want to hash out all of these diseases in detail because really they all lead to the same thing, various severities, but they're not going to look any different in how they manifest themselves. They all lead to the same thing. So the only way you're going to be able to tell the difference between them is on laboratories. So what can come out of hypercoagulation? So hypercoagulation, meaning that we're pushed too far onto the side of coagulation, so we're forming too many clots. So if we're forming too many clots, we're forming clots too easily, of course we can develop a deep vein thrombosis, which can lead to a pulmonary embolism, and that's one of the most feared things because our risk of pulmonary embolism is so much higher with these diseases. Myocardial infarction and stroke are also increased risk. Some of the obstetrical calamities, including abruptio placenta and preeclampsia, are also more common with people with hypercoagulation. And then Budd-Chiari syndrome of the liver and purpura fulminans in infants who are born with elevated coagulation. Okay, so here's what I wanted to get to. It doesn't really matter which hypercoagulation disorder the patient has. They could have factor V Leiden, they could have protein C deficiency, they could have lupus anticoagulant disorder. It doesn't matter. What is important is that you recognize the result in outward expression, which is an increased risk of thrombosis. Now, everybody can get thrombosis, but it doesn't tend to be young people. A 35-year-old doesn't get a pulmonary embolism. That's a 70-year-old with cancer who's bedridden. A 19-year-old doesn't come down with a heart attack. That doesn't make any sense. When you see those sort of what the heck's going on here questions, this is one of the things that need to be floating through your mind, because hypercoagulability can cause younger people to come down with diseases that we associate with older people. So what you should be thinking then is a younger person in their 20s to 40s or an older patient in their 50s or 60s, despite the fact that they're on anticoagulants. So we have what are called hypercoagulation panels, and they're performed frequently today. And what they do is they're just basically a panel of tests that go over all of the common coagulation disorders. So they look for the prothrombin mutation. They look for protein C and protein S levels. They look for factor V Leiden. They look for antithrombin 3 levels. They look for lupus anticoagulant. And it's all done in one panel. And so these hypercoagulation panels can be easily done anytime you have a patient who has a disorder that doesn't fall in line with the risk factors that they have. So the main implication is that any kind of hypercoagulation disorder significantly increases the risk of thrombosis, particularly deep vein thrombosis, compared to the general population. And the problem is rarely the disease itself, but rather it's when other risk factors come into play. So you could be a totally healthy 35-year-old man with factor V Leiden, and you have no risk factors for thrombosis, you're going to be fine. There's no need for treatment, you're fine. The problem is when any of these other risk factors come into play, you're going to be at a much higher risk than other people when risk factors come into play for them. So for instance, if you're a 30-year-old woman who has factor V Leiden and you get pregnant, you're in a much more problematic situation than if another 30-year-old woman gets pregnant. So some of the risk factors include oral contraceptive pills or estrogen supplementation, Pregnancy and the period after pregnancy, known as the puerperium. Prolonged travel because of the constant sitting, like on an airplane for 10 hours. Bed rest, trauma, surgery, renal disease, age, and so forth. So when these risk factors start to come into play, then we're more concerned about the fact that they have a hypercoagulability disorder. So it's good to know that they have a hypercoagulability disorder in advance so we can plan ahead. But a lot of times we don't get the fact that they have the hypercoagulability until after something significant has happened. So here's some of the hypercoagulability disorders, and you can see how some of these are quite incidental in the general population. So factor V Leiden, approximately 3 to 7% of people in North America have factor V Leiden itself. So this is almost exclusively in Caucasians. But having the factor V Leiden mutation increases your risk of venous thromboembolism by 4.3 times. So you're almost 4.5 times more likely to get a venous thromboembolism than somebody who does not have factor V Leiden. Now, some of the less common ones, like protein C and protein S deficiency or antithrombin 3 deficiency, they're much less common, but the relative risk for venous thromboembolism is much higher. So if you have a protein S deficiency, you're 32.5 times more likely to develop a venous thromboembolism. The prothrombin G2021A mutation, also another common one, but the relative risk is only about 2 times. Now the lupus anticoagulant disorder, the incidence is about 2 to 4%. It's much higher in patients who have lupus, who are diagnosed with lupus, who've gotten the positive diagnosis with the anti-dsDNA and anti-Smith antibodies, and they've got all the clinical features of lupus. But you can also have the lupus anticoagulant antibody and not have the disease of lupus. So the incidence is 2 to 4%, but it's higher in patients who have lupus. They're more likely to have the lupus anticoagulant antibody. It's about 30% to 50% in patients with lupus itself. And then the relative risk for venous thromboembolism is 4.6. So these are all good things to keep in mind. It's common ones being factor V Leiden and the prothrombin mutation, and then the relative risk is highest in the protein C and protein S deficiencies. Okay, so this is our coagulation pathway. You should have this memorized for the USMLE. It's really just good to know in general when you're working with clots and bleeding disorders. You've got to know this. Okay, so what is factor V Leiden? So factor V Leiden causes an increased coagulation because you have a mutated factor V. And that mutated factor V is more active and it's less able to be deactivated than normal factor V. So normal factor V can be deactivated by active protein C. Factor V Leiden is more active and is not as able to be deactivated. So because you have a much more active factor V Leiden, it's going to be much easier to, a much more active factor V, being factor V Leiden, it's going to be much easier to convert prothrombin 2 to thrombin 2A, which is really the rate limiting step in your coagulation cascade. So you're going to push this cascade in preference of cross-linking clots and stabilizing clots. And so that's factor V Leiden, and this is the most common hypercoagulability disorder. Okay, so protein C and protein S deficiency, this is less common, but it's more severe. So when you have a protein C and protein S deficiency, well, what are protein C and protein S responsible for? Protein C combines with thrombomodulin, which uses protein S as a substrate, and then results in active protein C. Active protein C blocks factor V from going into active factor V, and it blocks factor VIII from going into active factor VIII. So what you're doing directly is you're blocking active factor V, which converts prothrombin to thrombin. And you're indirectly blocking factor 10 to going to 10A because you're blocking 8 from going to 8A, and you need 8A to make 10 go to 10A. So you're directly and indirectly blocking both of the necessary components to make prothrombin go to thrombin. And so this is a very, 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 very potent way of anticoagulating. So the protein C and protein S are a sort of counterbalance to our coagulation cascade. Once you cut that out, if you have a deficiency, you're really going to push this cascade in preference of clotting. And this is why the protein C and protein S deficiencies are so much more severe in putting you at risk for venous thromboembolism. It's much rarer, but it's much more severe. All right, now if you have an antithrombin 3 deficiency, what does that do? Well, that is a reduction in antithrombin. What does antithrombin do? It blocks factor 10 from going to 10A, and it blocks factor 2A. So both of those are in the common pathway. And so if you have a reduction in the break, then you're going to have an increase in the activity. So you cut this antithrombin out, it's just going to lead to more cross-linking. This is an inhibitory factor of the cascade. So we got reduced antithrombin. And then with the prothrombin G20.21.0A mutation, you get increased coagulation because of increased amounts of prothrombin. And so the mutation just leads to increased amounts of prothrombin being thrown out into the serum. And if you have increased prothrombin, you've got more enzymatic ability to convert 2 to 2A. And that's going to, again, lead you towards cross-linking. So when should you suspect an inherited hypercoagulability disorder? As I mentioned before, thrombosis is something that a lot of people get, and the vast, vast, vast majority of them don't have an inherited hypercoagulability disorder. So if you have a 70-year-old who comes in with a DVT and it's unstable, you're not going to be thinking first, I want to get a hypercoagulability panel. 1, because the patient's not stable, but 2, it's not very likely that the patient has hypercoagulability, an inherited hypercoagulability, because age, risk factors such as cholesterol levels, and just overall health state, those are all going to be things that play into your risk of developing some of these catastrophes. However, if you have a patient who's young and who doesn't have risk factors that has one of these problems, then this would raise suspicions. So young, healthy, good cholesterol levels, not on oral contraceptive pills or supplemental estrogen, not pregnant, and so forth. So in patients with inherited hypercoagulability disorders, it's also very, very important, anytime, even if you're suspecting hypercoagulability disorders, to get a good personal history on the patient. If it's a woman, definitely ask her about her OB history. Has she had any pregnancy loss or miscarriages, difficulty getting pregnant, difficulty conceiving? And also family history, including do you have any relatives, close relatives, secondary relatives who have had MIs or strokes. And of course, everybody's going to say they've got family members who've had heart attacks and strokes. So what you really want to ask them is, have you had any family members who have had early heart attacks or early strokes, namely younger than 50? So clinical suspicion is reason enough to order hypercoagulation panel. And by hypercoagulation panel, I mean you're going back and you're looking at all of the possible things that could normally cause hypercoagulation, and those will assess for the major causes. In the US, the most common inherited hypercoagulation disorder is factor V Leiden, which has a 3 to 7% incidence. So that means up to 1 in 16 people could have factor V Leiden. This is Lipinski, She won the gold medal for figure skating in 1998 in Nagano, and she has a hypercoagulation disorder. She had a DVT on a plane and was subsequently diagnosed with a hypercoagulation disorder. Don't know which one it was, but it was probably factor V Leiden. But she writes about this in her book, and it just goes to show you can be an Olympic athlete, gold medalist, healthy, young, and you can still eventually possibly get a pulmonary embolism and die. She could have died from that. So definitely something to keep in mind for any patient, not just older patients. So how do we treat patients with hypercoagulation? And that's really the question, because there's some disagreement. So there's disagreement about whether to use long-term anticoagulants as a prophylaxis in patients whose only risk factors are their inherited hypercoagulability. Anytime you're using anticoagulants like warfarin or heparin, there's always the risk of bleeding. Now, what if you have a young 35-year-old and you're giving them anticoagulants and they hit their head at a party or something and they bleed into their brain? That's a problem. So we don't want to go overboard in treating patients if we don't have to. So if they only have if they're generally healthy and it's only the hypercoagulability disorder that's a problem, in general we don't treat them. So presently in patients with minimal risk factors, the strategy is going to be to control the risk factors that can be controlled. So if it's a woman, advise her not to take oral contraceptives or supplemental estrogen. Advise her against pregnancy. However, that's easier said than done. So if she does decide that she does want to get pregnant, then she should be made aware, obviously, of this condition and how it can affect her and her baby. And so definitely there should be communication with the OBGYN and with the maternal fetal medicine specialist. If the patient's going into surgery or needs prolonged bed rest, that may be an indication to anticoagulate them temporarily, not as a long-term therapy, but temporarily. If you know you're going to be on the bed for 2 weeks because you threw your back out, then that may be indication to start a short term of Coumadin. Comprehensive patient education, as in any disease that's chronic, but this is really important here because not knowing about this disease can lead to pretty catastrophic results. Acute care and follow-up of any thrombotic event, namely pulmonary embolism, DVT, it's unchanged. You treat it the exact same way you would for anybody else, but in general, patients who have already had a DVT or a pulmonary embolism, they're going to need to then go on long-term therapy. Because if you've already had one pulmonary embolism and you know you've got factor V Leiden or antithrombin 3 deficiency, then you're more likely to have another one. And so in that case, it's better to anticoagulate them with either warfarin or heparin. And then anticoagulation with heparin or low molecular weight heparins are often useful in patients who are pregnant. As a matter of fact, I would say it's standard if they have factor V Leiden or any of the other coagulability disorders. So generally this is done in consort with a maternal fetal medicine specialist. Coumadin warfarin is toxic to the baby, but the mother can then restart on warfarin after delivery. It isn't toxic through the breast milk. But generally in pregnancy, it's going to be pretty important to keep her anticoagulated. So keep in mind the risk factors and the fact that if you just have one of these disorders alone, you likely don't need to treat it. But once these risk factors add up, it really, really makes you think about the need to treat it. Make sure these patients are educated and treat them as usual if they have any thrombotic event. But then after that, you're going to need to put them on long-term therapy. And then one last thing, the lupus anticoagulant. We didn't really talk about this because there's not a whole lot known about this other than that there's a There's an increased incidence in patients with lupus. However, you don't have to have lupus to get it. It's called lupus anticoagulant, and that doesn't seem to make any sense since we're talking about diseases of hypercoagulation here. If you have lupus anticoagulant, wouldn't that make you more likely to bleed, not less likely to bleed? And the fact is, when this was named, it was because this was discovered in vitro. And in vitro, it actually does decrease blood coagulation. But in vivo, it's a procoagulant. So in your body, it does work towards coagulating things. But in the lab, it acts as an anticoagulant. So patients who are lupus anticoagulant positive, who are receiving therapy with warfarin, you should definitely keep this in mind because you're going to be following their INR. Where do you measure their INR? You measure it in the lab. So the PT may be falsely prolonged since that INR test is in vitro, and that's going to result in a false elevation of the INR. So if you're just following the INR and the patient is lupus anticoagulant positive, you may not be treating them enough. If you want to keep their INR between 1.5 and 2.5, and they're running at a 1.7, you might think, okay, that's good. But if they have lupus anticoagulant, their real INR may be something like 1.2, and that's not good enough. So it's not infrequent that a patient who is significantly LAC positive needs to be kept at an INR around 3 because of this confounding in the INR results. Luckily now we have a test called the chromogenic factor X, and this is something that will help us get around this. So when we're giving Coumadin to patients with lupus anticoagulant, usually now we don't have to worry so much about the false positives that we would get in the INR test. So the chromogenic factor 10 test. You don't really need to know that for the USMLE. It's good to know for real life. It's also good to know, though, for the USMLE that the lupus anticoagulant is a coagulant in the bloodstream, in the body, and an anticoagulant in vitro, in the lab. So don't let that trick you up. And that's it.